How serious is the opioid crisis? Find out now on this segment of More That Matters.
The opioid problem has been a worldwide issue for over a century, but it has now ballooned into a crisis here in Louisiana, in the U.S., and beyond. To manage the crisis, we must understand the nature of opioids and their effects. Here with her much-needed expertise is Melinda Robertson, the Louisiana State Opioid Response Project Director. Thank you so much for being with us today, Melinda. This is a very, very important topic. So many people have been impacted by this subject. Let's begin at the beginning. What is the opioid crisis?
Well, basically, it is what's happening right now with the overdose deaths due to opioids. From the 90s, we began seeing waves of prescription overdose deaths. And then later on, 2010, we started seeing heroin overdose deaths. And then 2013, we started seeing synthetic opioid overdose deaths. At some point in 2017, late 2017, it was declared a public health emergency.
So on a scale of 1 to 10, because you have the expertise to back this up, what would you say the number would be, how serious this crisis is in the U.S. and then here in Louisiana?
Over 500,000 people have died of overdoses, including prescription and illicit opioids, basically from the 1999 to 2020. In 2020, we saw an average of 45 people that died per day from overdoses involving prescription opioids, more than 16,000 deaths involving prescription overdoses in 2020.
Wow. It is sobering to have discussions about this. When was this opioid issue declared a crisis?
In 2017, by President Trump.
Do you believe the general population understands the gravity of this issue and how it is impacting families all across our country?
I honestly don't know, because sometimes I think people are aware, but as I go out and talk to people I know don't seem to be that aware. There's a lot of people with personal experiences having been prescribed opioids, right? We also have experiences where, we have family members who have maybe misused opioids. But I don't know that everyone really understands the gravity of the situation. I appreciate, shows like this that come around and you want to highlight what's happening, because we need to address it. Mm-hmm. It is the elephant in the room, and it's not going to be better unless people are aware and understand and stop stigmatizing it and acting like it discriminates, because it doesn't discriminate. Opioid use disorder does not discriminate. So,
because it's a sickness, not a weakness.
Right. It's not a weakness. It's unfortunate. I mean, it's just what can, it's a side effect of using this prescribed medication.
And it's so difficult too, as you said. This conversation is hard for some people to listen to. Our listeners to this podcast. Mm-hmm. That's why we do these, to make sure that we get the best, the most current, the most vital information we can to folks who need to hear. And as you said, that it's a conversation we have to have. It is critical to have. So let me ask, what led to this becoming an epidemic, to where we are right now? You said in 2017, all this changed, but it's been around for a while. So was there a tipping point? Did something happen?
So the epicenter was identified as West Virginia. So again, in the 90s, there was a high prescribing rate. There was a lot of marketing for opioids. There was a lot of prescribing and dispensing. Not real. There wasn't the best representation of the effects of using these prescribed medications. There was a situation with the depressed economy, socio-cultural factors. When you look at the situation, again, it wasn't a lot of information, and there wasn't a lot of information sharing back then. We didn't have electronic medical records. We didn't have prescription data monitoring systems, right? So there was, opportunity for misuse, right? So as we come along, and it, like I'm saying, epicenter is in West Virginia, but again, it was nationwide. So that was just identified as where it started, or where it was the most dangerous at the time that this became highlighted, right? But it's basically, prescribing for treatment for moderate to severe pain.
I'm just surprised when you said that the epicenter was West Virginia.
Everybody's surprised about that.
I would have thought New York or California. No offense to any of those wonderful states.
Sure. Well, but you're meaning that based upon population, how large.
No offense to anyone.
You're thinking about population.
Yeah.
But you got to think about what those factors are. Again, looking at where you see the prescribing of opioids is in larger towns and small cities. Right. So, and then you got to look at, those other factors like West Virginia is a high industry, right? It's like, that workforce class is high there because it's manual labor.
Right.
What happens in manual labor areas? What happens in the state of Louisiana? Yeah. Everybody works offshore. We have a lot of refineries. We have a lot of places where injuries occur. There's a lot of surgery. There's a lot of prescribing because we have, these situations where look at I didn't pull this information, but I can almost guarantee you if you look at the workers' comp claim in the States and do a correlational study, you're going to see with the prescribing, there could be a correlation there.
Interesting. Yeah,
right.
So what makes this so addictive?
So as with any drug or even, actions, and, there's parts of our brain that, are our feel-good centers, that activate the endorphins being released. And so again, I'm going to equate it to cupcakes. I see a cupcake, can't resist it. Like I want to play. And so it basically, I get the cupcake and I say, oh, this, really good. Love it. The adverse effects of it, gain some weight, right? But it doesn't keep me from eating that cupcake. So hence there's the addictive property, right? Gives you a euphoria feeling, right? Pleasure, pain situation, and the adverse effects. While there are adverse effects in taking opioids, they do not outweigh the pleasure of taking opioids, right?
We talked about the crisis in the United States, but let's talk about how it relates to our state, to Louisiana. Can you give us some information on that, Melinda?
Yes. So with some grant funding, Louisiana has actually invested funds into the Louisiana Opioid Data Surveillance System, which is a great system for any of the listeners out there to go and get information about the crisis in the state of Louisiana. And basically, we've seen a 432% increase.
Oh my God. Say that number again.
Opioid-involved deaths.
No, say that.
432% increase.
For over what time period? What time period?
from 2014 to 2021.
Gee whiz.
So, yes. So we went from 259 deaths per year in 2014 to 1,378 deaths in 2021.
That would constitute
So
a
total of
crisis.
4,744 people have had opioid-involved deaths. So, yeah, state of Louisiana, we're not the epicenter, but we are in there. We're part of it. The prescribing rate has decreased, but we had basically 72 opioid prescriptions per 100 people in 2021.
Now say that one more time. You have how many?
72 opioid prescriptions per 100 people.
That's 3/4. I mean, that's incredible.
Right. Uh-huh.
And you think about a state.
And it has decreased, but we are higher than the national average.
Oh, God.
Well,
in the state of Louisiana. So there's a lot of prescribing in the state of Louisiana. And there's actual parishes as in 2021 that had more prescription issues than people residing in the parish.
Oh, that just boggles my mind. How can that happen? I mean, how is it allowed to continue to happen?
Right.
With the prescriptions
like I said, it's a lot.
To what do you attribute that, though?
Number one, like I said, we have a lot of industry here. We have a lot of injuries. We have a lot of surgeries. We have a high cancer rate. So, like I said, these, they are prescribed. So you could consider them legitimate. I'm not saying there's any. I can't tell you if they're illegal or not, but what I can say is they're being prescribed. I can say that they have decreased, which is great. But the prescription rate is still high in the state of Louisiana.
Melinda, you referenced this earlier, just a second ago, actually. Many of these are prescribed. And in so many cases that end in an overdose, it started legitimately with a prescription that was dealing with some health issue.
And to help you, not to harm you.
That's exactly right. So, and again, don't know if I'm asking this the right way. How do we calibrate that? There are only 4.6 million people in the state of Louisiana. And with percentages that high, that impacts us in ways that that you have to look at with a more focused eye versus, say, a Texas or California. What do we do about that part of it? Why are doctors still prescribing at that rate? I know you referenced all the injuries, but has there been no calibration based upon the number of deaths?
I think that, to be honest, and this is an opinion of mine, kind of address stigma here. We look at people and we just say, that's not someone that's going to abuse this medication. I don't think that I can say right now, like personal and family history, and you can look at me, you see my face, you say, oh, she comes from a good family. Yeah, I did come from a good family. That doesn't mean that there aren't individuals in my family who haven't had issues with opioids. I've actually had. And I talked about an injury, and we talked about how this happens, and people don't, and I said it doesn't discriminate, right? People don't think it's not going to happen to me. Mm-hmm. The doctor looks at you, this isn't going to happen to you, and it does. It could happen to your brother, it could happen to your mom, it could happen to your grandmother, your sister. You don't know who's going to have it to, because again, you don't go into the office thinking, I want to abuse this medication. Nobody chooses to live that kind of life, right? But it happens, and it's hard for people to admit. It's hard for people to admit that it happened to them. It's hard for people to admit that it happens in their family. Until we get over this, it only happens to these type of people.
Yeah,
right.
Exactly.
Stop focusing on that and realize that, it could happen to you. It could happen to me. it can happen to anyone.
Yeah.
And once you realize that and put things in place and say, okay, I'm going to prescribe this medication. I'm also going to do a screen on you right quick to determine if this could be a problem, right?
And
it's education and training and, putting things in place, which we've done. We just got to get better at it and making sure that everyone's aware, like things like this podcast today, so that people know, right?
And we have to take ownership of our own health. The doctor is doing, obviously, what he or she thinks is necessary.
Correct.
For us to feel better, to get better, to be responsible, but ultimately it falls on our shoulders to do the right thing. So let me ask you, what are some of the commonly prescribed medications that are at high risk that people would become addicted to the opioids?
So you have the natural opioids, which includes morphine and codeine.
Okay.
You have the semi-synthetic opioids, which is oxycodone. Everybody's heard of Oxycontin.
Right.
Hydrocodone. There's some other words I can't say. I'm not going to say them words. There's the synthetic opioids, which includes methadone, fentanyl, and heroin, which is the illicit, right? So that's not prescribed. But so the ones that I said, morphine, codeine, you've all heard these terms.
Right. You
probably didn't, but I don't know. And you're right. How do you take control of your health when you don't even know that you're taking an opioid? So hopefully that's helped. We need to have this conversation of what is an opioid. And that's what you're being prescribed. And yeah, we do need to take ownership of our health and learn the facts about it.
Are there any precautions that a doctor or a pharmacy can take to lessen the chance of a patient becoming dependent upon some of these prescriptions you just talked about?
I think that screening could be helpful. I'm not a medical professional, but definitely screening to determine to look for the signs and symptoms is a precaution. And also just taking a good observation of the individual as they're working with them and making sure they're having good conversation with the individuals they're working with.
Because I could imagine if someone has had a surgery, an injury, or
they're in pain.
They're in pain.
They're in huge
pain. So they
pain.
come to you, they're legitimately in pain.
Yes.
And you're prescribing it to deal with the pain. But I'd like you to drill down a little bit more on this, though, because you're basically talking about an assessment of the person before making the prescription. And obviously, and you said you're not a medical professional, but what do you know about the assessments that are employed before a prescription is written?
There are brief assessments that you can look at, and they also look at their past history, right?
Mm-hmm. Yeah.
Have they had issues in the past with substance use? Did they have substance use in the family? So there's a lot of information that we put on these forms that can be used to kind of look at that. But also, asking the individual if they've had issues, look at behavioral health disorders, had they had issues in the past, and also look at the age of the individual.
Exactly.
Right. So there's some telltale signs. There are some screening tools out there that physicians can use, and there's also training that they can be involved in to look at that as well.
And the physicians, to a degree, they probably know that patient's history, and they have that's got to be so difficult, Clay. They're weighing the pros and the cons. And Melinda, we were talking about the fact that the patient just wants to feel better. And even in years gone by, not so much now with this crisis, but you heard about people, whispering, he had a back injury and got
Right.
addicted to pain medicine.
Right.
And that was 20, 30, 40 years ago. So it's been just hyper. Just now there's so much out there. And I don't know that people are afraid to talk about it. As we said earlier, Melinda, it's an uncomfortable conversation, but we certainly have to talk about it. So that leads me to the question, are there any legal mechanisms in place to restrict the overprescribing of these drugs, of these dangerous substances?
So, yeah, I can actually say that, there's regulations by the DEA, there's regulations by FDA, CDC, and then you got your state regulations. So there's a lot of regulations out there around the prescribing and dispensing of opioids. So that's helpful. We also have in place, like I mentioned earlier, the prescription drug monitoring systems, a program where we actually have to, anything that's dispensed or prescribed is monitored in those systems. And, hopefully we'll see some, regulations coming soon as far as, the training and education of medical professionals in the arena of substance use.
Well, I think that everyone, Clay and myself and you and our listeners, everyone agrees we're to a point that something has to happen.
100%.
Something,
yeah.
it should have happened yesterday, but now, it has to happen.
Right. We talked about this earlier and you referenced it, that's only going to affect, quote unquote, those people or people who live over there or whatever. And we know that isn't true, that this could befall any family in any part of our city or any city for that matter. But who would you say would be the most vulnerable population for the opioid addiction?
So those people that, again, have had, substance use issues in the past, for those individuals, that's a given. But younger people, people who, younger people tend to, engage in more risky behavior. Like the stigmatized. But we also have individuals who, I say younger people, but there are people who engage in risky behaviors, and those individuals are going to be more likely or vulnerable to opioid use or misuse. And then those individuals who have interaction with people who also misuse or use drugs. So there's these risk factors of, basically the highest risk factor is people engaging in risky behaviors. Those people that, and sometimes it is a cultural thing. It's like, prescription sharing and what have you. And like, oh, you don't need to go to the doctor for that. Let me get you some.
I've got something.
Let me go in my purse.
Gosh.
I mean, I'm from rural Louisiana, and I mean, you can't go to the doctor for that. Here, call your aunt, see if she's got something,
She have a little something that I can use. Yeah.
Yeah. So that's a social cultural situation, right? Like that's just what we do. And, we don't think about the consequences. And so that's probably, the worst part, we have this, oh yeah, we share everything around here.
Right. Well, some of
our Louisiana, we're the most generous people ever.
Yes, we are generous, are we not? But some of our listeners who are following us today and who have followed our podcast, they might have the question that it's kind of a stretch. It's kind of, how do we go from legally using this medication to going to stronger substances, to heroin? How does a patient or a person progress from legally and healthily using something to go to something stronger? Could you walk us through that?
Well, I'll take one personal experience, but not me personally, but what I've witnessed. And you have somebody in the hospital, they get in an accident, and this happened with people with accidents on the job too. I mean, it's basically you have a prescription And then you have, you're in the hospital a long time, or something's happened, you're prescribed. So I've seen your own morphine for a month, So here you are on morphine for a month. You get out, okay, now you're going to go through rehabilitation, and you're going to go, you're on the opioids. At some point, you're going to titrate off the opioids, but there's also these factors that go on. Also, there could be a bit of depression because when you're hurt,
true, yes,
in the hospital, you're isolated, and so it comes like a storm, right? So it's you probably may have lost your job because of this situation. Now you're stuck with all these medical bills. And so, as you can see, I'm building up on emotional stress and trauma, of what just happened, what my situation is. And then all of a sudden, I'm not feeling well. I'm in a lot of pain. And, again, you don't just wake up and say, I want to go see a drug dealer and do this. But that's what happens. Basically, you're going to go from morphine to, they try to put you on, you're not going to feel good with Tylenol.
Yeah.
So now you're going to go, how else are you going to go get it? You can't go get it from your doctor. You can't afford it. So now you're going to go to the street. You're going to get the heroin. You're going to get the illicit drugs.
It's a scary situation.
Made to look like,
it's just scary for a person to find themselves in.
And, and unfortunately, we've heard stories about people who progress down this road and end up dying from some substance that's laced with something that they're not supposed to put in their system.
And they didn't know. And
so they're attempting to get high.
Yeah, they didn't know.
Dying.
Yeah.
And that's something, I know people listening to this, and I think most people either know someone who's gone through it in their family or may have it in their own family, as you referenced. But this is an uncomfortable conversation to have because I think so often people don't want to seem vulnerable to something like this, which I think is not particularly healthy. However, if someone listening to you right now is curious about a friend or a relative that may or may not be dealing with this, what would you say are some signs that people should look for if they have those suspicions, or signs that they should look for if they don't?
So basically, number one, being prescribed opioids is not wrong.
That's a good point to make.
It's not
wrong.
Are
it's
legal
not wrong.
medications.
Yeah.
They are legal medications. So looking at, look at your mother and saying, my mom's using opioids.
Yeah.
That's fine. Okay. We want to look at changed behavior, right? Changed, increased use or risky use of their medications, taking them more than what they're prescribed or taking them outside of their prescribed directions, right? Cravings, physical dependence like sweating, craving, looking at change in weight, looking at are they drowsy all the time, and is there a change in their hygiene? And I purposely don't say an increase in weight or decrease in weight. I've read some articles and they say a decrease in weight. I say change in weight just because it's a change, right? It is a change that is out of the normal for the person. Somebody might have bad hygiene in particular, and their hygiene just kind of gets worse, right? So look for isolation. Look at, having financial difficulties, a change in illegal activities. Is there an increase in illegal activities, or is there increase in these things that they're doing, engaging in those risky behaviors? So those are the type of things to look for in individuals.
And
maybe using opioids.
And friends and family, they can see this, and they can see this in a loving way. And the person who is impacted, they don't want to accept it. Possibly, they don't want to believe. Oh my gosh, I become a statistic. I don't want, like you said, you don't want to do it. You don't wake up one morning and say, this is going to happen. And sometimes you refuse to believe that it's happened to you. So that's when you rely on friends in loving ways to be kind, to be loving, to help them, and not to criticize and not to tell them they're awful and they shouldn't have done. You don't need all that.
No,
you don't need that at all.
It doesn't help fix
It's not going to help. No. So what are some resources to help those that are impacted, whether or not be your family or friends?
So there's, if you're an individual, there's Narcotics Anonymous. There are grief groups out there for people who lose loved ones, family, friends, to opioid use. There's some prescription drop boxes. I think that's one of the last things we mentioned as far as that. I feel like it is anyways. I don't know if it is, but we forget, dispose of your medications properly. Store your medications properly. Use safe storage and disposal products. Look at parents of addicted loved ones, PAL, which is a group for parents of people who are using drugs. There's also the standing order for naloxone, and there's opioidhelpla.org, which, by the way, we're working on revamping that site to be a bit more comprehensive. So we'll see a lot of changes coming there.
And that was a website you said? I'm sorry, I missed that. That was a website?
Yes. Okay. opioidhelpla.org.
Oh, okay, thanks. Okay.
Yes. So basically, we'll see some changes. Right now, it lists where you can seek treatment and recovery support services. So we're going to add a lot of more information in there. So we're really excited about that. Kind of giving more information about what we're talking about today, really. So it'll be quite comprehensive. So that'll be a great resource. We're really looking at having that to be, basically in the state of Louisiana, where can someone go to get help? Or if you don't need help and someone needs help, that where you can go to get that information.
Correct.
And it includes physicians. So we're looking at giving resources to providers out there and how they can get more information and be better at their jobs and have resources to support them, because we got to support everybody.
And how important is not only recovery, but recovery and maintenance to maintain it, to stay off of this, and to know that you are susceptible, to stay, just to stay far, far away from all of this. We haven't talked, I don't think yet, about fentanyl. Oh gosh, you hear about this almost every day. What can you tell our listeners about fentanyl?
So that's a synthetic opioid. It is legally produced. Was originally made as an intravenous anesthetic around the 60s. Used to treat patients with severe pain following surgery. So it's quite potent. Basically, it is, let's see, to give you all some numbers, it's approximately 100 times more potent than morphine.
100
times more potent than heroin.
Oh my God.
Yeah, so
say that one more time.
Yeah, say those numbers again, please.
It's approximately 100 times more potent than morphine and 50 times more potent than heroin.
You can't wrap your head around that. That's hard to wrap your head around.
100 times. And you think about morphine and what it's given to you for surgery or whatever, and you said 100 times stronger.
Yes. So we're talking about, to overdose on fentanyl is we always use the example of grains of sand or the tip of a pencil. A little bit of sand on the tip of a pencil is used as a diagram to give you an idea of how little that is. It's not a lot. It's a tiny bit.
Well, we've read about incidents where law enforcement officers have gone into places and touched it with their bare hands and ended up overdosing and needing, and so it's impacted scenes now. And when say a narcotics unit goes into an area to deal with apparent fentanyl use or opioids there. I had this conversation with the commander of the narcotics unit in one of our cities here in Louisiana, and he said that they go in gloved, and in some cases they're very particular about who goes in because they don't want to have contact with this stuff because it is so potent.
Quite potent, and you don't know where it is. I mean, you don't know. Again, you just look at something and you're not going to say, "Oh, that's fentanyl."
Right.
You don't know.
Well,
nobody knows. Nobody
some
knows
of us
what
wouldn't
it's
recognize
in.
it anyway.
That's what I was going to. Is it a powder? Is it white? What does it look like, or how do you?
Yeah.
How do you? Okay.
It can come in a powder form. Yeah. It could be white. But yeah, but you're not going to know it any different. When you look at a pill that is made to look like Oxycontin or made to look like a Percocet, you don't know. You just see a white pill, or now they're making them in colors, but you just see a pill there, right? You're not going to see. It's not going to be labeled fentanyl, which is the most dangerous aspect of fentanyl, right? It's what you don't know what you don't know when you're taking these meds that are, supposedly prescription medications, because you're getting them. You're not getting them from a pharmacy.
Well, and
so anything you don't get out of the pharmacy, you just don't know what it is.
You do not. And you made the point that now they're in colors. So that's attractive. They look like candy. Or it looks like, oh, this couldn't harm me. This, it's too pretty. I just can't believe that when those statistics you gave just a moment ago, 100 times more potent than morphine.
That's incredible. You referenced earlier the population most at risk for opioid abuse. What about fentanyl?
So it's pretty much the same. I mean, as far as fentanyl is concerned, you're not going to get prescribed fentanyl unless you have, like I mentioned, severe pain is something that's going to be, severe.
So that will never be prescribed. Oh, is that what you said?
It's prescribed. Yes.
Oh, it could. Okay.
And I would say, yeah, it can be prescribed for sure. Anyone can be prescribed fentanyl, but as far as the people that are overdosing in most cases, from what I've read from the CDC, DEA, they're not overdosing from prescribed fentanyl. They're overdosing from illicitly manufactured fentanyl. And again, that's going out you can't get it anywhere else. So you're going to go out and you're going to get things, and you don't know what, the people that are giving it to you, I don't even know that it's in there.
Right.
So that's the scary part.
I know in some cities where we record our broadcast here in Baton Rouge, and I know here, and it happens around the state, that DEA has something called drug takebacks. And people should really search that to find out if it's near your city. And what it is they typically do it at police headquarters. You can take old prescription meds to them and just drop it off.
No questions asked.
No questions
just
asked.
Get rid of
You go through the line, they box them up, they take them to wherever they take them to be destroyed. And I often find, Melinda, that people don't know about that. If they haven't heard, they don't know. And they keep medication in their medicine cabinets for years because so many of us, and I've been guilty from time to time, not using all of what you have, especially as it relates to pain medicine. So it is not proper to flush that stuff down the toilet, but there are ways that you can get rid of it and get it out of your home. Can you talk about that just for a second?
Yeah, I'm glad you said that because people don't know. They just hang on. I do the same thing. I actually don't take prescription medication that much, but I am guilty when I do. I don't even pay attention that I even have it, to be honest, anymore.
Right.
But yeah, there are the prescription take back days. Then there's the prescription drug boxes. Actually, the Office of Behavioral Health funds a lot of prescription drop boxes across the state And there are pharmacies that actually have drop boxes as well. So I'll talk about opioidhelpla.org. That's one thing that we're adding to our site is a link to find those drop boxes because they are managed and monitored by the DEA. And they do keep an interactive map where you can find those drop box locations. Because you don't have to wait for a prescription take back day.
Yeah,
right.
That's what I'm saying here is you could take it any time to these drop box locations and take your medication. I actually had to use one within the last 6 months to take some medication because you do not want to flush it.
No.
You just go dispose of it properly. And we also fund some programs around the state that give out the Terra bags. And those are bags that you can actually put your pills in and it'll dissolve them.
Really? I didn't know that.
Yeah. So you can actually take, and it is safe. It makes it safe that you can actually, you just pour it out in the sink or whatever. So there are those little bags. And those are easy to use as well. And then locking up your medications. And
right, of course.
Just put them in your cupboard.
Yeah.
And there's all kinds of, we fund those as well, like the medication bags that you can lock and put your meds in there and lock it up so that they don't get into the hands of anyone in the house.
Right. Exactly. It's wonderful options to know. I don't think we discussed it or we haven't talked about it in our closing minutes, but I think it's very important for our listeners to understand and know the long-term effects of the abuse of opioids. Could you say a few words about that, Melinda? I'm sure you've seen that and know about it.
So, yes. So there are long-term effects. Again, I'm not a medical professional, but I've even seen this. So one time I used opioids. I'm going to use my own personal experience. I had I had my tooth removed, the molars in the back, and yeah, right. So I got the dry socket, and I was like, oh gosh, no, this is bad.
Yeah.
So I use opioids, and so one of the is constipation. So as you can imagine, with long-term use, that it does affect your immune system. It can cause bowel obstruction, myocardial infarction, tooth decay. I don't know if a lot of people realize that it actually affects your teeth. Immunosuppression, hyperalgesia, chronic constipation, breathing problems during sleep, and serious fractions, which was surprising to me when I was searching this on CDC's website. Yeah, so interesting, right? But I know that the few days that I used them, I just could not use them again. I probably would not. I would have to say no to that. No matter, I would have to look at the alternative pain management. And there are alternatives to pain management. So,
and see, that's important. I think a lot of people think, well, there are no alternatives. What do I do? I have no other option. So thank you for mentioning that as well. So that is a critical piece of information right now. As we're wrapping up our cast today, we've had, oh my gosh, so much critical and important information. Is there anything, Melinda, that you can think of that we need to make sure that before our listeners, before they leave this particular podcast, that they really need to know or a thought they should be left with?
We talked about opioids. We talked about the dangers. We talked about what happens and how you can get there, but we didn't talk about the harm reduction aspect, and that is, the naloxone. Some people know it as Narcan.
Yes.
And that's brand name.
Yes.
Yeah. Having naloxone, when you go get, if you're prescribed opioids, you can ask for a prescription for naloxone, but the state of Louisiana has a standing order for naloxone.
Yeah.
So you can actually go to your pharmacy and ask for naloxone and get it. And insurance should pay for it, or there might be a copay.
Yeah.
But that's something you need to talk to your doctor and your pharmacist about, making sure that you have naloxone on hand. And when you know that you suspect a family member is using, get you some naloxone. We'll be working on, there are areas of the state where, we have naloxone for free. where you can get naloxone. We're working on some vending machines to get out to the state to dispense naloxone.
Fabulous idea. Fabulous.
So, So we actually have a vending machine in Shreveport right now. But get your naloxone, learn how to use it. It's especially the intranasal spray, really easy. So just make sure that you have something and know the signs of an overdose, and know that, always call 911, even if you have naloxone, because it's not a long-term solution when you have somebody that's overdosing. And the good thing about naloxone is if you suspect somebody is overdosing and they are not, it's something else, it's not going to hurt them to administer the naloxone.
Good point.
So,
excellent point. I didn't know that either. Yeah.
Right. So I could use naloxone on myself right now, and it's not going to do anything to me. So just know that you suspect it, use it, and call 911.
That's so great. And that's a relatively recent thing that you can get Narcan over the counter now. Is that correct?
As of yesterday, we had the press release rolling in about over the counter naloxone. Yeah. So that'll be rolling out this year. That's super exciting. But again, we're with the state of Louisiana. We are, dispensing it for free, so it's no cost to individuals.
Excellent.
So it's great to have it over the counter. However we can get it out is the best to make sure it's available.
We've had a lot of critical information today.
Oh, yeah.
And this is a conversation that needed to happen. And we are so pleased here on this podcast to be the vehicle to bring this to our listeners, to help them know and to understand this, because it is an epidemic and we want our listeners to be safe. We want people in our state and across the country, our loved ones and our families and friends, to be safe. So Melinda, thank you. Thank you so much for helping our individuals and our families. And we so very much appreciate your expertise. And we thank all of you who joined us today for this episode of More That Matters. Thank you for being with us today.